Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 31. We're going to talk about the DNA envelope viruses. Specifically, we're going to talk about the herpes virus family and the pox virus. There's a lot of members of these families and they cause a lot of diseases. We'll try to go through them clearly so you can remember them clinically. Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 31. We're going to talk about DNA enveloped viruses. This is a busy table, but it's important and it's good to memorize for the test. On the top three sections, we have the parvovirus, papillomavirus, polyomavirus, and adenovirus. These are not enveloped viruses, and we're not going to talk about it in this module, but it's good to have them here for comparison. In contrast, we have herpes virus, pox virus, and hepatinovirus, which are enveloped DNA viruses, and we're going to talk about each of them in turn. As I said, the DNA enveloped viruses are herpes virus, pox virus, and hepatinovirus, all three of these cause important human disease. The herpes virus has a number of families in it, which each cause an important disease. Herpes simplex virus causes HSV1 and 2. Varicella zoster virus causes chickenpox. Epstein-Barr virus causes EBV. Cytomegalovirus causes a number of diseases. HHV6 is a cause of roseola. HHV7, we're not real sure exactly which diseases it causes, but it's been implicated in a few. And HHV8 is associated with Kaposi sarcoma and primary effusion lymphoma. The herpes viruses are enveloped, they're icosahedral nucleocapsid, they're double-stranded DNA, and their synthesis takes place in the nucleus. They can enter the latent state in the host, and latency depends on the virus. With HSV, it becomes latent in the sensory ganglia and resides there until reactivation occurs. In HSV2, it happens in the sacral region, and in HSV1, it happens in the trigeminal ganglia. HSV1 and HSV2 have different appearances and clinical presentations. HSV1 classically causes oral herpes with cold sores and herpetic keratitis with a dendritic ulcer. It can also cause HSV encephalitis and meningitis and eczema herpeticum. HSV2 classically causes genital herpes, proctitis, encephalitis, meningitis, and infection of neonates. There can be mixed match with HSV2 up in the oral region and HSV1 down in the genital region. Herpes infection is characterized by painful skin vesicles. The clues include a blister-like lesion and also recurrences along a dermatomal pattern. Eczema herpeticum is seen in children with active eczema or pre-existing atopic dermatitis, and it spreads over the skin at the site of the eczema lesions, and it also spreads to the liver and to the adrenals. Here are some pictures of clinical herpes disease. You can see here that it forms numerous blisters and vesicles. It happens around the mouth and along the trigeminal ganglion. You can also see a Zank prep with the inclusion bodies found in cytopathology. Neonatal herpes includes congenital defects or intrauterine death. The neonate can also acquire the infection during delivery if the mother has active genital lesions. You'll get painful skin vesicles, pneumonia, encephalitis, hepatic and adrenal necrosis. Viral causes of neonatal encephalitis, you should think of HSV1, HSV2, and CMV. Lab diagnosis of herpes includes a Zank smear, which is a scrape of cells from the base of the lesion. Then you do a Giemsa strain, and you'll see multinucleated cells with inclusion bodies. You can also look at cytology and histology. You can do shell vial cultures. You can do direct fluorescent antibodies. Frequently, we're using PCR for things as dangerous as HSV encephalitis. In terms of treatment, herpes viruses do very well with acyclovir, valcyclovir, or famciclovir. Also, you try to avoid contact with the virus. Inclusion bodies are shown in this figure. You have Cowdery type A inclusion bodies. They're eosinophilic nuclear inclusions with a halo. You can also form a syncytia or multinucleated giant cell. Like we talked about, anti-herpes drugs include acyclovir and valacyclovir, penciclovir and famciclovir for HSV and VZV. CMV doesn't have a thymidine kinase, and so you need to use ganciclovir or valganciclovir. Sometimes we use cidofovir and foscarnet for CMV retinitis. Here's a question. The selective action of acyclovir in herpes infections is due to which of the following? So before we look at the answers, we need to see what does acyclovir do and how is it selective. We know that it affects viral infected cells and it acts on the viral thymidine kinase. The host doesn't put the first phosphate on the thymidine, it uses the viral thymidine kinase that it competitively inhibits with that. As we look through the answers, A pops out immediately as what we're looking for. The viral thymidine kinase phosphorylates acyclovir more effectively than host cell enzymes. We know it doesn't bind the viral receptors on the affected cells, it doesn't target the RNA polymerase in the virus, and it doesn't prevent budding. Next question. During the period of latency, herpes simplex virus type 1 most commonly resides in D, the trigeminal ganglion. This is something that anybody who's had a cold sore knows. It goes all the way up there and it can come along the trigeminal ganglion, it can get in your eye, it can get along your forehead, right along where the trigeminal nerve goes. Next question. A 21-year-old woman has several tender, painful vesicular lesions at the corner of her mouth. She's had 2 previous episodes. Further workup implicates an enveloped DNA virus as the offending pathogen. The most likely agent is... This is a case of herpes simplex, and it's HSV is the answer. Measles doesn't show up as a recurrent vesicular lesion. Chickenpox is going to be one, it's going to be all over the place, and it's going to be in different stages. And Coxsackie-A, although it can cause hand, foot, and mouth disease, isn't going to be recurrent like this, especially it's not a DNA virus. Next question. An immunocompromised person with a history of seizures had an MRI that revealed a temporal lobe lesion. Biopsy showed multinucleated giant cells with intranuclear inclusions. The most likely pathogen is... So a pearl for doing well in step 1, or a pearl for remembering herpes simplex encephalitis, is that it has a predilection for the temporal lobes. Even if we didn't know that it likes the temporal lobes, we could see that it showed multinucleated giant cells with intranuclear inclusions. So we know we have a herpes simplex virus situation going on, and that's what answer A is. Hepatitis is unlikely to cause a brain infection. Coxsackie virus probably could, and parvovirus could, but neither of those are going to show the multinucleated giant cells with intranuclear inclusions. Next question. A 22-year-old sexually active female presented with fever, chills, myalgia, and painful genital lesions. Subsequently, she got a headache, photophobia, and a stiff neck. Pelvic exam reveals extensive vesicular and ulcerative lesions on the labia minora and labia majora, with marked edema. CSF VDRL was negative. Cultures from the genital region and from the CSF identified double-strand DNA virus. The most likely pathogen is... So even if we didn't have the encephalitis going on or the meningitis, the most likely pathogen for vesicular lesions on the genitals is HSV type 2. Okay? We also know that HSV type 2 can also cause meningitis and encephalitis, and so A is the right answer, herpes simplex virus type 2. Varicella zoster virus is the most common cause of chickenpox. It also can cause shingles later in life. It's diagnosed clinically by the distribution and nature of the rash, and also by PCR if you need it. Treatment of varicella zoster includes valacyclovir and famciclovir. This prevents disseminated infection in immunocompromised people. You can give varicella immunoglobulin within 72 hours, but otherwise it's supportive care for comfort. Prevention includes a new live attenuated virus vaccine called Varivax, which has been shown to reduce postherpetic neuralgia. Varicella or chickenpox is highly contagious with epidemics in the winter and spring. There's a 2-week incubation where you have viremia and dissemination through the bloodstream. Patients often have fever, malaise, headache, then they get a rash which starts on the face and trunk and spreads to the whole body. The vesicles are described as a dewdrop on a rose petal. You've got a red base with a fluid-filled vesicle on top. You get crops of vesicles in different stages. They scab in 1 week and the patient ceases to be contagious. You can get complications like pneumonia and encephalitis. Shingles is a reactivation of a latent infection along a single dermatome, often associated with postherpetic neuralgia, with burning and paresthesia, and the virus resides in the cells of the dorsal root ganglion. Questions. A 7-year-old boy with no past immunizations develops a pruritic maculopapular rash that quickly changes into thin-walled vesicles with clear fluid. The lesions started on the trunk and spread to the body with the exception of the palms and soles. New lesions continue to develop as another crop forms scabs. The most likely diagnosis is... When you have somebody who hasn't been immunized, you think of something we normally immunize against. Then when you talk about these vesicular rashes that show up in crops, starting on the trunk, going to the extremities and sparing the palms and soles, you have to think about varicella. That's a classic description. Which of the following drugs can be used to prevent disseminated varicella infection in immunocompromised patients? So A. Acyclovir is a drug we use for herpes virus. Ribavirin, nevirapine, and AZT are not going to be used for herpes infections. Cytomegalovirus virus has the largest genome of all herpes viruses. It only replicates in human cells, and it forms multinucleated cells, or syncytia. The characteristic staining inclusions look like owl's eyes, as shown here in these figures. The infected cells become swollen and big, or have cytomegaly. Transmission of CMV is spread in secretions, usually by saliva, urine, breast milk, vaginal secretions, or semen. You can get it in blood products, or frequently in transplanted organs, in utero. When you think about an in utero infection or congenital infection, you think about common pathogens, and the mnemonic here is TORCHES, where you think of toxoplasma, other, rubella, CMV, HIV, herpes, and syphilis. Clinical findings of congenital CMV disease include microcephaly and sensorineural deafness. They often have what's called a blueberry muffin cutaneous rash, and it's due from hemorrhages. You can have periventricular brain calcifications, hepatosplenomegaly, and it's very, very dangerous. You can have a 30% mortality rate. Even the survivors often have neurologic sequelae. Perinatally, the infection is usually asymptomatic. Question. A weakly asymptomatic newborn infant has CMV antibody titer of 1 to 32. Which of the following is the most appropriate next step? So the question is, does this baby have CMV, or is this some random titer? If you have a baby that you're considering having CMV, you want to make sure that you've confirmed it. So repeating the CMV titer immediately might be a good idea, but let's look at the other answers as well. We could wait 6 months and obtain another titer on the baby. I don't think that's appropriate. If they've got CMV, you'll want to treat them as soon as you can. You can obtain an anti-CMV IgM titer from the mom. You can obtain an anti-CMV IgM titer from the baby. Well, we know it's not going to be C, because antibody titers from the mom are not going to be very helpful. IgM from the baby is going to be helpful because IgM won't cross the placenta and therefore will have been produced by the baby. Okay? So if we have that, we know that the baby has been recently exposed to CMV, and the baby is mounting an immune response. Repeating the titer may just give us the same information and won't give us anything new. Next question. Which of the following lab tests would be most useful in establishing a diagnosis of congenital CMV infection? A. CMV IgG titer of the neonate serum at birth. That's not going to be as helpful because IgG can cross the placenta and may be just from the mom. B. CMV IgG titer of the mom serum at the birth of the infant. That's going to give us the same information as A. It's going to tell us how much IgG the mom is making. C. CMV IgM titer of the neonatal serum at birth and at 1 month of age. That makes sense. Like we said before, IgM can't cross the placenta, and so if you find IgM in the baby, it's from the baby, and if it's making anti-CMV IgM, it's been exposed. D. Total IgM on neonatal serum at birth. That's going to be less helpful, especially because we can use the paired titers in C to see if it's going up or going down. CMV has a different manifestation depending on the patient, whether the patient's immunocompetent or immunosuppressed. 80% of adults have antibodies against CMV because we've been exposed and didn't have any illness. We can have kind of a mononucleosis-like syndrome, and we can have a negative heterophile antibody test. But if you're immunosuppressed, you get bad disease. You get CMV retinitis, interstitial pneumonia, colitis, esophagitis, encephalitis. The immunosuppressed patients are often bone marrow transplant patients, and they can get CMV pneumonitis, and that can kill them. You can also get a systemic syndrome 2 to 4 months after the transplant where you have fever, malaise, leukopenia, thrombocytopenia, and abnormal LFTs. You can get involvement in the retina and in the CNS, but that's less common. Where you get CNS involvement in the eye is in AIDS. There you get CMV retinitis. And this picture in the slide shows retinal opacification, which is the white stuff, edema and necrosis, which are the little white spots, hemorrhage you can't see very well, but you'd see that as red, fluffy white exudates, and vascular sheathing. It's classic for CMV retinitis, and it's common in AIDS patients. Lab diagnosis for CMV includes serology, looking at IgG and IgM titers. You can also do a biopsy, and you can do histopathology and looking for the inclusion bodies. If you do a CT and you find CNS calcification, that's a good indicator. PCR is going to give you a definitive diagnosis, and you can look for PP65 antigenemia. Okay? Treatment for CMV cycles around ganciclovir as the first-line agent, foscarnet, and cidofovir. Like I said, you can look for inclusion bodies like the owl's eye and the multiple speckled cytoplasmic inclusions. Questions. A 35-year-old HIV-positive patient with AIDS presents with blurring of vision. Fundoscopic examination of his retina reveals opacification with fluffy exudates, hemorrhage, and vascular sheathing. Most likely pathogen? In step 1, if you have somebody with AIDS and something in their eye, it's almost always going to be CMV. It's going to be hard to go wrong with that. What clinches the diagnosis is the fluffy exudates, the hemorrhage, and the vascular sheathing. Next question. A 35-year-old bone marrow transplant recipient presented with dysphagia, difficulty swallowing, and weight loss. Endoscopy and biopsy of his esophagus reveals characteristic owl's eyes inclusions. The most likely pathogen is. This is a classic setup for CMV. We've got a bone marrow transplant, they've got problems, and you do an endoscopy, and you've got owl's eye inclusions. That's going to give you CMV every time. Those are the catchphrases you want to be familiar with. A 29-year-old HIV-positive patient presented with blurring of vision. Examination of his eyes revealed large yellow-white areas with flame-shaped hemorrhages. He responded to therapy with ganciclovir. The most likely pathogen is. This is kind of the same question we had before. It's cytomegalovirus. Next question. A newborn is infected in utero with an enveloped virus containing double-stranded DNA. The child develops petechiae, jaundice, hepatosplenomegaly, periventricular brain calcification, and sensorineural deafness. Most likely pathogen? When we think about the double-stranded DNA viruses, and we think about which ones cause neonatal infections, we think about CMV. Herpesvirus is not going to show up with the hepatosplenomegaly or the periventricular brain calcifications. It's going to be more likely to have temporal problems. Hepatitis B we didn't talk about, and Toxoplasma is not a double-stranded DNA virus. Question. A newborn infant develops painful skin vesicles, along with pneumonia, hepatitis, encephalitis, disseminated intravascular coagulopathy. He develops, subsequently, massive hepatic and adrenal necrosis. The mom had similar painful vesicular eruptions in the vagina during delivery. The most likely pathogen? This is more of the situation with HSV type 2. Mom has lesions on her vagina. We've got encephalitis, hepatitis, pneumonia, and DIC. That's going to be more consistent with HSV. Contrast that with the previous question where we talked about CMV. HHV6, or human herpes virus 6, is a T lymphotropic virus. It's the causative agent for roseola, also known as exanthum subitum, or 6 disease. It happens most frequently in children who are 6 months to 3 years of age. You get the abrupt onset of a high fever up to 104 degrees, and it lasts for several days. After the fever breaks, you get a rash of an erythematous maculopapular rash on the trunk and the face. The rash lasts for a couple days. Questions. A 6-year-old girl presents with an erythematous maculopapular rash of 3 days duration. Her history is remarkable for a very high fever of 4 days prior to the appearance of the rash. Which of the following is the most likely diagnosis? This is roseola, just like we talked about HHV6. Next question. Which of the following statements regarding roseola is true? A. It's also known as exanthum subitum, or 6 disease. Yes, that's true. B. It's also caused by human herpes virus 6. Yes. C. It's caused by human herpes virus 8, which is no. So D, A and B only is the correct answer. Epstein-Barr virus is the infectious agent for mononucleosis. It also causes Burkitt's lymphoma with a T1814 conversion. It causes nasopharyngeal carcinoma. In HIV patients, it can cause oral hairy leukoplakia. And if you're immunosuppressed, it can cause lymphoma. It only affects cells that express the receptor of CD21. It's a complement C3d receptor, and it's found on B cells. And also you find it on oronasopharyngeal epithelial cells. You've got some clinical features here of nasopharyngeal carcinoma, oral hairy leukoplakia, and what the cell prep looks like with Epstein-Barr virus. The life cycle for EBV has a lytic cycle where there's active infection, production and release of infectious viral particles, and B cells and some epithelial cells are infected. This manifests as IM, or oral hairy leukoplakia. The latent cycle is more common with B cells infected, and they become immortalized. In this situation, you're more likely to get Burkitt's lymphoma. In this case, you have transformation of the c-Myc gene from one chromosome to another chromosome, and the genome may integrate randomly in host chromosomes. Clinical findings of infectious mononucleosis, most people are familiar with these: malaise, lymphadenopathy, painful exudative pharyngitis, hepatosplenomegaly, fever, and a rash. Complications include meningitis, encephalitis, myelitis, Guillain-Barré syndrome, splenic rupture with a large number of B cells, so don't let your kids play sports while they have mono. Transmission is classically known as the kissing disease because you get close contact with saliva from infected carriers. Questions. A 40-year-old patient develops lymphoproliferative disorder following a renal transplant. The most likely virus responsible for the post-transplant lymphoma is... When we think about post-transplant lymphoma, so if you think about post-transplant patients, you worry about CMV. But if you're talking about a post-transplant lymphoma, you worry about Epstein-Barr virus. Because EBV affects B cells, it's a common cause of lymphoma. Epstein-Barr virus is not associated with which of the following malignancies? So Epstein-Barr virus is associated with Burkitt's lymphoma, nasopharyngeal carcinoma, oral hairy leukoplakia, and post-transplant lymphoproliferative disorder like we talked about in the previous question. It's not associated with squamous cell carcinoma of the cervix, but HPV is. Lab diagnosis for EBV includes blood smears, where you'll look for atypical reactive T lymphocytes, which are called Downey cells. You can get a mild thrombocytopenia, and you can get a positive Coombs test. You also look for heterophile antibodies, which is also called the monospot test. You can also call it the Paul-Bunel antibodies. These are produced by proliferating B cells. It's IgM antibodies that agglutinate sheep red blood cells, and they're diagnostic of acute EBV infection. You can do ELISA serology for the viral capsid antigen, the E antigen, or the EB nuclear antigen. PCR is also helpful. Treatment for mono and most of the EBV symptoms is supportive care. Specific antibody tests for EBV help you discriminate between acute infection. The most important or most useful antigen is the viral capsid antigen, IgM. It's the first one that you show up, and if you have IgM to it, you know you have an acute infection. IgG to the viral capsid antigen persists for life. If you have anti-EA or early antigen, that antibody arises early after the VCA but disappears within a few months. When you have anti-EBNA, that appears last and persists for life after recovery and is a marker of previous exposure. So in the acute, you have viral capsid IgM or a four-fold rise in the IgG for the early antigen. If you have past infection, you have IgG for the viral capsid antigen and for EBNA. Question. An 18-year-old college student develops fever, sore throat, lymphadenopathy, splenomegaly, and the monospot test is negative. The next diagnostic test is EBV titer. This is where you can use your serology, look for the viral capsid antigen, EA antigen, or EBNA. The heterophile titer is the same thing as the monospot test. Chest x-ray is not going to help you with EBV, and neither is a bone marrow biopsy. Next question. A 14-year-old adolescent male has mono-like symptoms with a fever, sore throat, and lymphadenopathy. The tests for mononucleosis and EBV titers are negative. One of the causes of heterophile negative mononucleosis is, so we talked about something that can cause a generalized mono-like symptom in an immunocompetent person. CMV is the first thing you want to think of. It's related to EBV. It doesn't cause the skin vesicles that you're always going to see with herpes virus, herpes simplex. Adenovirus and Coxsackie viruses aren't going to form this fever, sore throat, and EBV-like syndrome. Next question. Which of the following statements regarding the heterophile antibody test or monospot test for infectious mononucleosis is false? So A, it's a primary screening test for infectious mono. That's true. It's a good screening test. It's easy to do. B, the test measures cross-reacting IgM antibodies. That's true. They react with the sheep red blood cells. C, early in infection, the heterophile test may be negative. That is true if you haven't had a chance to make antibodies yet. Or D, the heterophile antibody response is long-lasting. That's not true. It's usually transient, and so it goes away. Next question. A 16-year-old African-American male developed massive unilateral enlargement of his lower face in the region of the mandible. Biopsy of the lesion demonstrates sheets of medium-sized blast cells admixed with larger macrophages. The lesion is identified as malignant. Which of the following viruses has been associated with this type of malignant lesion? So we should know that African Americans in their mandibles are susceptible to Burkitt's lymphoma. We have a lymphoma here. Our choices talk about viruses which cause lymphoma. EBV we know can cause lymphoma and causes Burkitt's lymphoma. Hepatitis B can be associated with cancer, but that's usually hepatocellular carcinoma. Herpes simplex virus is not associated with cancer. HPV is, but that's cervical cancer and not Burkitt's lymphoma. Pox viruses are also DNA envelope viruses, and there's a number of these. There's orthopox virus, variola virus, vaccinia virus, and unclassified pox viruses like the molluscum contagiosum virus. Variola is a smallpox virus, and it's double-stranded linear DNA. Vaccinia is of historical interest because it causes cowpox, and that's where Jensen first did the vaccine strain from. Smallpox virus is a complex brick-shaped virus. It's double-stranded linear DNA. It has a virus-associated DNA-dependent RNA polymerase, and it is unique among the DNA viruses because it replicates in the cytoplasm. It has 7 to 17 days incubation. The exanthem is most common on the face and on the extremities, and it's synchronous progression, which is different from chickenpox, which will have grouped vesicles in all different stages, some crusts, some vesicles, some ruptured vesicles. Fortunately, smallpox became eradicated in 1997 and only exists as a terrorist threat now. Diagnosis is based on Guarnieri bodies, which are cytoplasmic inclusions, and they're found in infected cells. Prevention is through the smallpox vaccine, which the military still has available to it, and live attenuated vaccinia, or cowpox virus. There's enough crossover that we can stop smallpox by giving cowpox to people. Molluscum contagiosum virus forms small, pink, benign wart-like tumors all over the body. They're umbilicated and they have flesh-colored papules. They're a benign proliferation of epithelial cells, and you'll find molluscum bodies inside them, or also Henderson-Patterson bodies in the cytoplasm. They are a problem in immunocompromised hosts and will make you think of somebody infected with HIV as well. This is a picture of what they look like.
Wrapping up Module 31, we talked about the herpes virus families and the pox virus families. Herpes is a very clinically important series of viruses that you need to be familiar with. Both the herpes simplex viruses with oral and genital ulcers, you need to be familiar with varicella zoster and shingles as it shows up later in life. Epstein-Barr is a common cause of mononucleosis. Also, you have the human herpes virus 6 for 6 disease, and you have HHV8 for Kaposi sarcoma. Finally, CMV can show up in a neonatal or congenital infection, and that's going to be very different than you see CMV mostly in the eye in late-stage AIDS patients. Pox virus family, you'll need to know about molluscum contagiosum, and of historical interest is smallpox, which we fortunately have been able to eradicate, and there hasn't been a single disease since 1978. This is a big group. It'll be worth your time to go back and be familiar with the clinical presentations. You should know about acyclovir and ganciclovir in treating herpes virus infections, and you should also be familiar with the diagnosis of pox virus infections. Smallpox is going to show up with synchronous lesions, which is very different than chickenpox. You'll see it in a bioterrorism-like setting, if they ever ask you about that. Next up, we're going to go to the DNA non-envelope viruses in Module 32.